Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone, and we're glad you can attend Attitude's weekly ADHD Experts webinar. Sorry for the late start. We had a few technical difficulties at our end. Just an introductory note before we get started. If you've listened to one of our webinars before, you know we've been experimenting with adding a certificate of attendance. When the webinar ends, a post-event survey will pop up. It will list 3 questions about the quality of the webinar, followed by 3 questions titled Required for Certificate. If you would like a certificate of attendance emailed to you, you should answer those 3 questions. If you're not requesting a certificate, don't bother answering the questions. Now, today's topic is a challenge for many people diagnosed with ADHD. Finding the right ADHD medication and figuring out a dosage that delivers maximum benefit with the fewest side effects. The best way to do this is a collaboration between you and your doctor. You should have a frank talk about your symptoms and areas of your life that you would like to improve. And your doctor should listen closely and assess your symptoms appropriately and accurately. He or she should be knowledgeable about the full range of stimulants available and, equally important, skilled in adjusting the dosage to achieve optimal benefit. We are happy to have Dr. William Dodson here to give adults, parents, and clinicians the strategies for finding the right medication for you or your child. As Dr. Dodson says, ADHD medication is not a treatment of last resort, but the first-line treatment of choice for those with ADHD. Dr. Dodson is a board-certified adult psychiatrist who has specialized in treating adults with ADHD for the last 25 years. He was named a Life Fellow of the American Psychiatric Association in recognition of his clinical contributions to the field of ADHD. Dr. Dodson has a consultative practice in Greenwood Village, Colorado, and is a member of Attitude's ADHD Medical Review Panel. You can ask questions of Dr. Dodson anytime during the webinar. We will try to get to as many of them as we can after his presentation. To download the presentation slides of this webinar, click the drop-down menu labeled Event Resources on the bottom left of your screen. If you do not see the Event Resources tab, you need to refresh the page. So now finally, let me turn it over to Dr. Dodson. Great to have you here today, Bill, to help us with this important and often confusing topic.
Great. It's good to be here. Okay. Good afternoon or good morning, depending on where you are. The question that keeps on coming up over and over again is, once you get on medication, people ask, is that all there is? Is this all that I can expect from having ADHD medication? These medications are extremely effective medications, some of the most effective medications in all of medicine. But we really don't give people a way to really assess how well they're working or could be working for you as an individual. Generally, we use 4 types of assessment methods. The most common one, I'm sorry, this is not advancing. Oh, yeah. The most common one is that people just raise the dose until there's some obnoxious or intolerable side effect, and then they back down a dosage level or 2. That's quick, it's simple, but mildly unpleasant. And, you know, for those of us who like to do things scientifically, it is kind of random. The second one is we can use standardized scales that were designed to assess progress in treatment. They were originally designed to do so in research studies of these medications. The one that is probably most commonly used is the Connor Global Index Scale. He has 2 forms of them, one that's filled out by parents, one that's filled out by teachers. They're actually exactly the same. They ask exactly the same questions in a different order. And the third one is we have a direct measurement of performance using a computer, a CPT, or a continuous performance test. And examples of those would be the TOVA, which is the test of variables of attention, the quadrant, the Connors, and 10 other different CPTs that are all knockoffs of the TOVA. The TOVA was the first one, it's the longest one, and the one most commonly used. Also, clinicians use what's called a SWAG, which stands for a scientific wild ass guess. And we'll talk about how that's done in just a moment. So let's look at the Connors. The Connors is normed by both age and gender between the ages of 3 and 17. So this is for children and adolescents. Separate ratings are done by parents and teachers because the teachers really see kids with ADHD in the setting that's most likely to bring out the impairments of ADHD. Sitting quietly, waiting your turn, paying attention even though somebody's not dealing with you but rather somebody else in the class. This is the place where people are going to have the most trouble with ADHD. The assessment takes less than 10 minutes to both fill out and score. There are 10 questions rated on a 4-point scale, 0 points for this is not true at all about my child, to a 3, which is very much always true. It's then divided into 2 subscales, restless impulsive and emotional lability. And it's important that you notice that these are the 2 things that are, going to be causing the most problems for kids in school, but they're really not asking that much about attention span. They're really looking more at behavior. So the 10 questions are on the restless impulsive side. Is the kid, is this very true or not at all true that my kid is restless overactive, excitable impulsive, fails to finish things started, inattentive or easily distracted, fidgeting, disturbs other children, his demands must be met immediately, there's a very low frustration tolerance. Over in the emotional lability section, having temper outbursts, cries easily, mood changes easily and drastically. To me, that looks like they're asking about the same thing 3 times, but nonetheless, this works out fairly well. The scales are done at the beginning before the kid ever starts on medication or before there's a psychotherapeutic intervention. You get a baseline. Then the scales are done for medication, usually on a Friday, after the kid's been on the this new medication for at least a week. You can also do them periodically just as sort of a judgment call if you're looking to see what cognitive behavioral therapy is doing for the kid. That last line is a bunch of jargon from statistics, but a T-score less than 55 or a percentile score less than 73% are what a non-ADHD kid would score. So what we're going to be looking at is lower scores are better. And so this is how it would look. You'd start off at no medication, and do a baseline, and then you'd give a dose of medication, and sure enough, the kid improves. There's a lowering of the Connor Global Index scale. You try a higher dose of medication, and there's continued improvement. Bring it up again, there's continued improvement, maybe not as quickly, but with an increased dose again, it sort of levels off. It doesn't get any better, and adding on another dose after that, things start to actually get worse. So the optimal lowest score, which is back there at 15 milligrams, is that child's optimal dose. Giving more doesn't make him any better, and in fact makes him a bit worse. So in a very objective way, looking at the child's behavior, you can sort of figure out what dose is getting the very best response. It's very similar when you're doing the computerized continuous performance testing. These are, for those of you who took psychology courses, these are called go, no-go tests. In other words, you either respond or you don't respond, and it measures 2 things: vigilance and attention, being able to look for what's coming, and impulse control. If there are impairments in vigilance and impulse control, these measure it from any cause, not just ADHD. So if somebody's having trouble with impulsivity, it could be due to being intoxicated. It could be due to a head injury and that sort of thing. These studies are highly IQ dependent, and people with very high IQs can overcome the testing situation. People who can hyperfocus can turn in absolutely normal-looking tests. Like the Connors, it is normed by both age and gender. Girls do much better than boys on all of these tests. Also, it's designed to be done in the morning because people perform much better in the morning than they do in the afternoon. The pros are kids can't give you feedback. They don't have very good self-appraisal skills. They can't really tell you what effect the medication's having on them. These CPTs directly measure distractibility and impulse control. They're normed. The TOVA of all 13 CPTs is the longest, so it really stretches the attention span, and it can very objectively determine dose. Again, highly IQ dependent, measures impairment from any cause. And so this is what a TOVA would look like. On the screen, for just 0.2 of a second, one of these two figures will flash. When the rectangle with the square top flashes, the kid's supposed to punch the button as quickly as they can. If the other one with the square at the bottom flashes on the screen, you do nothing. So if the target is there, but the kid's mind is on the dark side of the planet Neptune, and they don't punch the button, an error of omission, that's a very good measure of inattention. If the non-target is there and they punch the button anyway, that's an error of commission, and it's a good measure of impulsivity. So sitting there doing something, a mindlessly boring task like that for 22 minutes is really going to stress a person's ability to pay attention and continue to do so. And again, you'll see the exact same sort of thing. You'll start and get a baseline, then you'll give a dose of medication, you'll see improvement, you increase the dose, and you see further improvement. Well, if you go beyond that point, actually you lose performance and you pick up side effects. Prior to that optimal dose, that top of the V, there are no side effects other than a mild loss of appetite. When you go past that and you start picking up side effects, they're generally categorized either as the Starbucks syndrome. Imagine what somebody would look like if they rolled out of Starbucks after 3 double espressos. Jittery, irritable, agitated, heart beating fast, that sort of thing. Or some people, usually very hyperactive people, can get the exact opposite, and that's the zombie syndrome. They lose facial expression, they slow down, they become dull. Zombie. So again, you don't want either one of those. You want to stop at the top of that curve. There also, with adolescents and adults who can give us feedback, we can use what we call the SWAG, the scientific wild-ass guess. Even adults are going to have poor self-appraisal abilities, but usually they can go ahead and give you enough feedback about what they're seeing. The educational part of management is to learn these impairments in their lives and then learn how to get around them, learn compensations. So if you're currently on medication, you can do this right now along with me. I'm going to ask you to rank or score your medication, the one that you're currently on a scale of 1 to 10. And when you do this, I don't want you to overthink it. Give me your first impression about what score you would give it. A 1 is just god-awful, nothing but side effects, no benefits at all. And a 10, on the other end of the spectrum, is the very best you can imagine a medication ever working. Okay? Have you thought about a score? This is how most clinicians do it. We're shooting for scores of 8, 9, 10. that is a very good response to medication. For most people, the lowest acceptable score is a 7. Scores of 6 or below are generally not acceptable because experience has shown us that if you have a good experienced clinician and a motivated patient, almost always through some manipulation, changing medication or whatever, we can get most people up into the 8 to 10 range. Now, this sounds very crude, but it usually works, and it saves about $3,000 worth of assessment testing. So it's certainly something that you can do before you spend that kind of money. So let's say that your medication is not optimal. You think it's working at about a 5. How do we go about optimizing medication? Medication gets you in the game on a level playing field for the first time so that then you can learn how to manage your ADHD. If you look at the MTA study, the multimodal treatment study of attention deficit hyperactivity disorder in children, that's why it's called the MTA, what they found was that medication alone and medication plus intensive behavior treatment were pretty much equal. Adding the behavior treatment did not really help. It was better than behavior treatment alone, and it was much better than what these kids were getting out in their communities from their local clinicians. What they found there was that almost every single child was grossly underdosed. The doc would raise the dose to the first sign of positive benefit and then stop. They would not optimize the medication. At 3-year follow-up, they still hadn't optimized. So while you hear people complaining about the side effects when the dose goes too high, by far the most common pattern seen out in the real world is that docs don't raise the dose and get optimal response. They also tried the NYU McGill study. This was a 2-year study trying 7 different therapies added to people who were on medication. And the bottom line is there was no support for or advantage from adding any of it. So what I'm trying to get at here is that medications are where you need to start. They are by far the most effective treatment of ADHD. So what should you reasonably expect from medications? I'm going to be using a technical term here. It's a statistical term called effect size. It's much more math than I can do. So it allows us to take studies done at different times, different places, but compare them with a basic idea of how well did this particular treatment work as compared to all the other treatments I might have tried. It's probably the best available, even though it is somewhat on the crude side. Remember that effect size is comparing the responses of groups, not individuals. So you and your personal response may vary from what you're about to hear, what you read in the literature. So the effect size of the first-line stimulants, this is methylphenidate and amphetamine, is very good. In research studies where they use what's called a forced dose methodology, in other words, they just assign a dose to an individual. It's not fine-tuned. We get an effect size of 0.95, which is very, very good. That's going to be better than the vast majority of other medications and treatments in all of medicine. If we fine-tune the dose, we optimize it, and we go above the FDA maximum doses that are listed, you can get an effect size of up to 1.8, which is better than practically anything else in medicine. The alpha agonists, when they work, and they work for about 60% of people, again, get very robust effect sizes, 1.1 to about 1.3. Atomoxetine, that's Strattera, which is the non-stimulant medication, is somewhat less than that. It works better for kids than adults. For kids, it's got an effect size of 0.6, and for adults, down about 0.44. Now, this, as compared to stimulants, looks a bit disappointing, but when you compare it to the other things that we use in mental health, the SSRIs, either for major depression or anxiety disorders, Even what looks like a poor result from atomoxetine only looks poor because it's being compared to stimulants. It actually is right in there and competitive with all the other medications that we use in mental health. So we actually, in ADHD, have remarkably good treatments. So medications, whatever you feel works best for you or your child, are the first-line treatment of choice. In every international standard of care, that's what they recommend that you start with because they're the most effective, the safest, most thoroughly studied medications that there are in all of medicine. Generally speaking, they tend to be underdosed. But the thing not to forget is they are the treatment of choice, not the treatment of last resort when everything else has failed. Oops. So, is one of the stimulant molecules better than the other? The answer is yes and no. In large groups, the answer is no. The effect size is the same for methylphenidate and amphetamine. The rate of response is the same. The side effects are the same. So it doesn't matter on those things which one you choose to try first. In the real world of clinical practice, however, we don't see groups, we see individuals. And individuals usually have a very clear preference for one agent over the other. Nothing predicts the optimal molecule. It doesn't run in families. So you can have a family where one kid takes an amphetamine product, one other kid takes a methylphenidate product, and the parent takes something else entirely. Everybody is a unique individual that needs to be treated individually. So this is just a comparison of the two molecules, their excretion. Amphetamine tends to be a bit smoother in its kinetics, and so it doesn't have as severe a rebound. It still has a rebound, but it doesn't have this severe rebound that methylphenidate or Ritalin does, hence the alliterative term Ritalin rebound. If you took 100 people, 37 of them would clearly like amphetamine much better. 26 of that 100 would clearly like methylphenidate much better. The rest could take either molecule and be perfectly happy. So that the robust response rate from stimulants is about 85%. Again, much, much better than any other medication in mental health. Then, once you've decided on a molecule to try, then you should look at the time-release, extended-release stimulant formulations. You get much more consistent and stable benefits because, by definition, people with ADHD are forgetful, they're disorganized, poorly structured, more likely to lose things, they're easily distracted from even the most important activities. They have a poor sense of time about when to take the medication, and they're extremely sensitive to teasing and embarrassment. These longer acting medications keep the kid from having to pick up in the middle of the school day, walk down to the school nurse to get their dose of an immediate release formulation. So while immediate release formulations are clearly cheaper, they are usually a false economy because people don't continue to take them or they don't get around to taking them. So how do you then determine the dose? Remember that the techniques that you might read in a research subject, such as forced titration or so many milligrams per kilogram per day, make terrible clinical practice because there is no parameter that predicts either the molecule or the dose in advance. It doesn't vary on the basis of weight, age, gender, scale scores, severity of impairments. Nothing at all predicts either the molecule or the dose. Every person must have the dose and timing of dose fine-tuned to their individual needs, and it then needs to be readjusted about once a year. The American Academy of Pediatrics suggests once a year until about age 16 or 17, at which time that locks in and a person's on that dose for the rest of their lives. Here's that upside-down V curve again. This is, again, TOVAs. computerized continuous performance tests. And again, what we're looking for is to be at the top of that V, because there you're getting optimal performance and no side effects other than maybe a mild loss of appetite. More is not better. You see the performance drop off very quickly, and that's where you pick up the extra side effects. So how do you figure that out? Well, we use a target symptom approach. What is it about your ADHD that bothers you the most that you want to make sure we get rid of with the medications today? So we tend to choose target symptoms that do respond well to medication, and they're listed there. Sustained engagement, listening, procrastination, restlessness, that sort of thing. But we also avoid target symptoms that really are not that well affected by medication. Organization is the big one. Organizational skills do not come in pill form. Sense of time, but also the more ODD type of thing, argumentative, disobeying rules, being up in the face of parents or teachers, that sort of thing. So we list the patient's target symptoms. We usually have 4 or 5. Then we start whichever medication the doc's feeling lucky with that day at the lowest dose that's available. And then you increase the dose periodically. For children, it's usually about once a week. With adults, you can change the dose every day. But as long as the patient is reporting that they're seeing continued improvement each time there's a dosage increase and there are no side effects other than a mild loss of appetite, you can keep increasing the dose. It's when you increase the dose and don't see further improvement, then you know that the previous dose was the lowest dose that gives optimal performance. You're not quite done yet, because then once you've found the best medication and dose, we ask our folks to lie down after lunch and take, while they're on medication, and take a no-risk nap. Prove to themselves that when they're on medication, they actually sleep better. Most people with ADHD will say, I've never napped in my life. Well, once you're on your optimized medication, it slows down all the chatter in your head, the restlessness, and most people with ADHD can nap just fine. Then you'll know that if you need an afternoon or evening dose, you can take one, and the medication will not keep you awake. Something else might, but at least with this no-risk nap, you know that the medication's not the culprit. Is there really a maximum dose? The answer is there's no clinical or research basis for the notion. This is an administrative, bureaucratic notion coming from the FDA's pre-marketing trials. And there, they just arbitrarily set a dose. And when they say it's the maximum dose, what they're really saying is this is the highest dose we studied, and we cannot guarantee that it's safer to go higher because we didn't study it. These maximum doses tend to remain very low due to regulatory concerns. But the American Academy of Child Medicine Psychiatry, in its last standard of care, gave a list of all the medications that were available at the time and gave what they called off-label maximums that were anywhere from 50 to 100% higher than what the FDA listed. So it's certainly possible to go beyond what the FDA has put in its package inserts. You just need the doctor needs to document that they had continued improvement of symptoms without side effects each time they raised the dose, and that the blood pressure and pulse rate didn't change from baseline. The most sensitive, specific measure that you're having a bit too much medication. For the doctors out there, it's that you're seeing autonomic nervous system hyperarousal, is the second number in the blood pressure. As long as you're below the optimal dose, the diastolic pressure, the second number, doesn't change. The minute you go past that, the diastolic pressure goes up 10 millimeters of mercury. And it's a very sensitive and specific measure that you've gone past what that unique person's optimal dose may be. You also have to tell the patient about what to expect in terms of the speed of onset of action. The stimulants are immediately effective as soon as they reach the brain, so you're going to see very quickly that day everything that medication is ever going to do. All the benefits, all the side effects are usually evident that day. The backloaded delivery systems like Concerta may take 6 hours to get the maximum blood level, and that's where you measure it, but it's at least that day. The alpha agonists, on the other hand, take 5 days for the benefits to fully develop, so the quickest you can increase the dose there is once every 5th day. Atomoxetine or Strattera takes up to 6 to 8 weeks for it to fully develop benefits, and that's after you've titrated up to a tolerable blood level. So their medication trials can last several months. What about those people, that 15% of people who try both stimulants and don't get a good response or don't tolerate either one? That's very common. That's 1 in every 7 people will try both stimulants and not be able to make use of them. Oddly enough, for something that happens so frequently, there's nothing in the literature or in the standards of care that would tell your doctor what to do next. So what follows is what I and other clinicians who did a lot of work with people who were, quote, treatment failures tend to do in this situation. The first thing we do is we check to make sure we've got the right diagnosis, that this really is ADHD. We can make mistakes, and we want to go back and make sure we didn't. If we do think this is ADHD, and the patient didn't see either benefits or side effects, they took the medication and just saw nothing, that means that it's not being absorbed. We make sure that the person takes the medication but avoids medications and foods and things like that that are high in citric acid or vitamin C. The only 2 products that are immune to that are Vyvanse and Daytrana. If it's not being absorbed out of the GI tract, we give the patient a trial on a skin patch, a transdermal delivery system called Daytrana. Then most people will try the alpha agonist because all by themselves, they still have a pretty robust effect size. Unfortunately, the response rate to either molecule is somewhat low at only about 30%. How do you decide which person you're really going to give this to? Again, if you're on medication, try this out for yourself right now. I ask the question, can you remember a time at any point in your life longer than about 5 minutes in which you have been both mentally and physically at peace? Now, at peace is not exactly a scientific term, but it's the appropriate one here. Somebody who's going to really do well on an alpha agonist is going to get a good chuckle and say, are you kidding? No, I've never been at peace. I've always got 4 or 5 things going on in my head. I always have way too much energy. I can't sleep at night. I'm impulsive. And I am very, very emotionally labile and very vulnerable to my perception that I've failed or I've been rejected. So these are the people who you really want to give a chance on an alpha agonist. These are the types of things that they'll work very well for. Then I try atomoxetine, Strattera. It has a fairly high side effect burden and about a 50% response rate. Finally, after you've tried everything else, and that's a big if, you can find somebody to prescribe it, you can try methamphetamine. Most doctors don't know that methamphetamine is available by prescription, that it was the first medication the FDA ever approved for ADHD back in 1949. But let's face it, it carries huge, huge negative connotations. Just the word gives most parents and patients the willies. But nonetheless, more people get a better response with fewer side effects with methamphetamine than with any other medication we've found. It's just that it's the only one that has abuse potential. If you take that 15 out of every 100 people who got no benefit from anything else, about 60% of them will get very robust response with methamphetamine. The doses that are used are very low, about 1/100th of the doses that people use when they're abusing it. Finally, last slide. How do you find a clinician that knows what they're doing? The American Academy of Pediatrics just put out their updated guidelines last week, and they have a 47-page document there that talks about systemic obstacles to treatment. And they note that half of all pediatricians and 90% of all adult psychiatrists receive no training at all on how to diagnose and treat ADHD. So you have at least a 50-50 chance of your pediatrician going, I don't know how to do this, go someplace else. So where do you go? You can go to the professionals list at Attitude Magazine. One of the best places to go is to a CHAD meeting or an ADDA meeting. That's the Organization for Adults. You can ask a school counselor. You can ask an ADHD coach. All of these people have experience with this, and they know who's good with this and who's not. And they can save you an awful lot of time and money. Speaking of money, you probably need to be prepared to pay out of pocket for a specialist in ADHD to do the initial assessment. Once all your medications are set, they're pretty much set for a lifetime, and any willing provider can write the prescriptions for you. So that is a real fast overview about what to do, and we can now open it up to any questions that are out there.
Okay, Bill, that was great, insightful, comprehensive, and quick. Loads of questions. I know you can't answer all of them because you can't prescribe, but I'll ask
recommendations over the phone.
Right. So, one adult says, I've been on stimulants for years. Do scientists know if they change your brain or why their effectiveness might decrease?
Well, the multiple layers to answer that question. There have been a lot of long-term studies. The Milwaukee study goes back to the 1960s. And thus far, all of the risks of taking stimulant medications are in not taking them. All of the different things that can go terribly wrong if you have untreated ADHD are the real risk. Thus far, there have been no identified long-term risks of these medications. The FDA themselves did 3 huge studies about cardiovascular problems, 7.3 million people, and they basically said there is no added risk for the cardiovascular system from taking these medications. Every once in a while, about once a year, you'll have a study done by somebody who usually doesn't do these studies, where they'll come up with, there's an increased risk of, the most recent one was Parkinson's disease in people who take ADHD medications. Thus far, when people then go back and try and reproduce those results, they're not reproducible. So you will see studies out there, but they're non-reproducible. So they're extremely, extremely safe. Why would they stop working? The most common reason is that somebody changes what they eat, and now they're washing down their medication with fruit juice, something that's high in either citric acid or vitamin C, and that's preventing the absorption of these medications out of the GI tract. When you look at the package insert of ADHD stimulants, that's the most common drug-drug interaction that's listed. And yet nobody operationalizes it and says, and this is what it means to you in day-to-day practice. It'll keep these medications from being absorbed. Every once in a while, about 1 in every 600 people, the medications will suddenly just stop working. The most common reason for that is a woman going into menopause and losing estrogen. Estrogen seems to be necessary for these medications to work. But also this sometimes happens to men, and we really don't know why that happens, but it just appears that the medication can't get from the blood into the brain. But again, that's a scientific wild-ass guess.
Mm-hmm. A parent is asking, what are the best questions to ask your child about continued effectiveness of the medication? Are there ways to get at the needed information to make sure the dosage is optimized? I guess this is a parent asking the kid.
Right. That's why I strongly suggest that you do things like the Connors or something like that. no kid, whether they have ADHD or not, has that ability to turn around, observe themselves, and say, how am I feeling? How am I performing? I mean, that's why we ask the teacher to give them grades. So the things I would look at would be the Connors. Has that score started to drift up again? Have their grades started to drift down? Those grades every 6 to 9 weeks are a very good measure of how well the medication's working. So those are very objective. If the kid's having side effects, usually the kid will tell you about it. I feel awful on this medication, or I hate when it wears off at 3, and I'm tearful and irritable and things like that, and therefore need another dose of medication. But usually the kid is not going to be a good source of information. If I had to choose one source of information, it would be the classroom teacher. That teacher who's taught the second grade for 30 years knows what a normal second grader should be doing. And so they should be able to give you the very best feedback about what the medication is doing for your kid.
A parent is asking, should we take a break from our ADHD medication? If yes, why and for how long?
The answer is no, never. If your kid were wearing glasses, would you want to take a break from that? He was taking insulin. Would you want to take a break from that? ADHD does not go away. It works its mischief every day, all day, 24 hours a day, and the medication is going to be beneficial. The whole notion of, and I hate this term, medication holidays, came from some concerns years ago that medications for ADHD caused a slowing of growth in some children. I think that worry has been pretty much put to rest by the work of the guys at Harvard in particular. There are still some people, though, mostly people who've never prescribed in their lives and generally are kind of anti-medication, but you will find some studies out there that say that kids who are on medication, their growth does slow down, but then compensates. There's a rebound of growth at about 2 to 3 years. I have not seen that, but the research is out there. So for most kids, I say be on medication all the time. If you look at the things about ADHD that are going to kill you, it's not school. You're never safer than you are when you're at school. But when you're off medication, your risk of serious accidents goes up 400%. Your risk of developing a substance use disorder goes up 400%. Your risk of having an unplanned out-of-wedlock pregnancy goes up tenfold. Your risk of being involved in the juvenile justice system goes up 700%, and on and on and on. All of the risks are associated with not being on medication. So I'm kind of foursquare, always be on medication. Because the real risks are happening evenings, weekends, holidays, summers. They're not happening in school. That's your time of biggest risk. So,
I guess a grandparent has asked, the meds that my grandson has been taking are not working now. His pediatrician won't give him the time of the day on this topic. Who can I go to for help? He is now 14 and has been on this same med since age 8. So I guess she just wants to discuss the topic with a clinician, but the clinician is not interested in really discussing it. So, I mean, there have been several questions about that, the clinician not being cooperative or wanting to talk about things. Do you have any advice for people who come up against that?
Well, first I would ask the question, would you tolerate this if your child were diabetic? Would you tolerate that if your child had pneumonia? And the answer is no. You wouldn't put up with it for a second. the doctor doesn't want to address something that's right in front of him. For whatever reason, basically, he doesn't want to talk about it. If he's doing this with ADHD, he's probably doing it with other things. You need to find a new doctor. And again, go to that last slide. How do you find a new doctor who is not just comfortable with talking about ADHD, but highly experienced and really likes doing it? I love working with ADHD patients because you get such great results. One of the things in the field is, where else in medicine can you turn somebody's life around this afternoon the way you can when you recognize and treat ADHD? So you want somebody who has that attitude. I really love doing this. And so you go to a CHAD meeting, you ask other parents who's good, who's not. Because, somebody who you're saying, help me, and they're turning you a cold shoulder, dump him. I'm sorry, that's not exactly political to say that, but that's what you need to do.
Right. What would be the best course of medication for someone who has both Tourette's and ADHD? There are several articles on your website about that, and I would refer the person to there. But the notion that the stimulants will make Tourette's and especially any tic disorder worse is maybe. More people have their tic get better or not change at all than it gets worse. So just having Tourette's, just having a tic is not an absolute contraindication to using stimulants. Unfortunately, you just have to try it and see. You start low, you go slow, but the majority of people can take the first-line stimulants. The other thing to do is to take caffeine out of the person's diet. The most potent trigger of tics known to man is caffeine. And so a lot of times the kid will be drinking 2 Mountain Dews a day, but the increase in tics gets blamed on the ADHD medication. So I really don't do anything until caffeine has been removed from the diet. 50% of people will lose their tics if you get rid of caffeine. If the person has an increase in tics and the tics are either impairing or embarrassing, then I would go to a second-line medication. The alpha agonists, and especially clonidine, actually have an FDA indication for the treatment of tics. And so that would be one I would immediately go to. Uh-huh.
So it would be that order: remove caffeine, add in an alpha agonist such as clonidine, then try the stimulants again and see if the tics actually get so bad that they are either impairing or embarrassing. Nothing gets rid of tics entirely, so you need to set that bar there. But as long as they're not impairing or embarrassing, you're okay. You'll never get rid of them, though.
Mm-hmm. There have been several questions about combining stimulants with non-stimulants. Do you want to address that?
Well, the ones that are most commonly combined are the alpha agonists because they hit different aspects of ADHD. If you look at what the stimulants do, they do one thing exceptionally well, and that is if you're engaged with something, it keeps you from being distracted. And they do a marvelous job of that. Where the stimulants don't address, hyperarousal, having 5 thoughts in your mind at the same time, inability to shut off all the chatter in your head so you can sleep at night, and they don't address rejection sensitivity. And so since the 1980s, we have used these old blood pressure medications, clonidine and guanfacine, added onto a stimulant to handle those 5 things. Hyperarousal that you can't sleep, rejection sensitivity, multiple thoughts, impulsivity, that sort of thing. And so we add in the alpha agonists in addition. And that happens so frequently that the FDA approves them for use together. You can also add in Strattera, I guess a little bit expensive, but you can do it. And that has the added advantage of when the stimulant wears off, you've still got something to take you through the evenings, homework at night, help you fall asleep at night, that sort of thing. So those two are very commonly used together. But remember, the stimulants are going to be much more effective than Strattera.
Mm-hmm.
So those are the combinations that you see very commonly out in clinical practice.
Yeah. How does puberty affect medication dosage?
It's really hard when kids hit puberty. I mean, all of a sudden they're nuts, and so you see lots of personality changes at puberty. The place where you'll see probably the biggest effect is in women, girls, when they start menstruating. Girls with ADHD will have premenstrual dysphoric disorder much more frequently and much more severely than the general population. And we think, the best theory, and it's probably right, is that when estrogen goes to zero, which is what causes the menstrual flow, the ADHD medications don't work with a hoot. So for a period of 3 to 5 days before the menstrual flow, people will say, my ADHD medications just don't work anymore. Raising the dose doesn't make a bit of difference, and it requires the menstrual flow and estrogen increasing again for the medications to work. I mentioned this also about at the other end where women go into menses and again don't have estrogen. The medications don't work nearly as well for those women.
Mm-hmm. And lastly,
that would be the boost.
Oh, sorry.
Go ahead. Sorry.
Yeah, the sleep problems that kids have, or some kids have, or some adults have, taking stimulants. That's been brought up several times, and I wondered if you just basically had a strategy to dealing with sleep problems, or do they fade, for instance, like appetite problems, over the course of weeks or months? What is your best strategy for dealing with sleep problems?
Okay. There are two types of sleep problems. One, the most common one, is intrinsic to ADHD itself. Penny Corkum at the University of Halifax, Nova Scotia, has done most of this work. And what she points out is that when kids come in, elementary school age kids, they've never been on medication. 25% of them have 2 or more sleep disturbances. So sleep disturbances are part of having ADHD. The big one is an inability to shut off your brain and body to go to sleep at night. The history you get from children, adolescents, and adults is, Doc, I'm a night owl. I've always been a night owl. When the sun goes down and it gets fully dark, everybody else is getting quiet and ready for bed, I get a burst of energy. And I know that if I get into bed, I can't shut my brain and body off to go to sleep for at least 2 hours. That is the sleep disturbance of ADHD, and oddly enough, it will respond to the stimulant medication. That's what you do that no-risk trial nap for, is show yourself that the medication actually helps you to sleep. What people believe will happen is what's going to happen. So if somebody believes the stimulant's going to keep me awake, you can bet your bottom dollar that it will. So you need that no-risk trial nap to confront that belief. Now, the other group of people who they didn't have any sleep disturbances at all until they started the medication. That group, usually the dose is just a little bit too high. First thing I would do is I would lower the dose and see if the insomnia goes away. Mm-hmm. If that doesn't work, and the person is taking an amphetamine medication, it only works for amphetamine. Amphetamine's not metabolized in the body, it's excreted, and so it has an off switch. if you give somebody a real big dose of vitamin C, and that's what Airborne, Emergency, Juice Plus, whatever, if you give somebody 1,000 milligrams of vitamin C, it's immediately flushed out in the urine, and when it does, it takes all the amphetamine with it. And so it's like a big off switch, so that you can actually just get all the amphetamine out of the person's body. It takes about 20 minutes. They get in bed and they sleep normally. But those are the two things I would try for people who did not have sleep disturbances before, or if they don't take the medication on weekends, don't have the problem on weekends, that sort of thing. So they're two totally different groups of patients.
Oh, that's great advice. Bill, I think the hour is up.
Okay.
You gave us so many insights and also practical strategies. Everyone appreciated it. I know I did. Thanks for being here and sharing your expertise.
Sure. Always a pleasure.
Yeah. Thank you again, Bill. And thanks to all the attendees for being here. Hope you will attend next week's webinar on November 21st, when then Ned Hallowell and John Rady will talk about the flip side, as they see it, of rejection-sensitive dysphoria. They call it recognition-responsive euphoria. So it ought to be a good one. And thanks for attending today's webinar, everyone, and have a great day.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com.